Welcome to Habitual Excellence, presented by Value Capture. This podcast and our firm is all about helping you and your organization achieve habitual excellence via one unifying focus, one value-based structure, and one performance system. In other words, it's about helping you capture dramatically more value through achieving perfect care and perfect safety for patients and staff. To learn more about Value Capture and our services, visit www.valuecapturellc.com.
Welcome, listeners and viewers. We're excited to have you. You know that you've joined us on Habitual Excellence, the podcast where I have the privilege of speaking with leaders, top clinical and operational leaders in healthcare who tend to be visionaries and people who have sat in the seat and use the principles of habitual excellence, of creating sort of world-class operating systems driven by values to produce great outcomes. And they tend to have great, timeless and timely thoughts to share with their peers who are attempting to do the same thing as healthcare is ever changing. And that is certainly the case today. We are joined by Dr. CJ Kunnappilly, and CJ is the Chief Executive Officer of the San Mateo Medical Center, which is a division of the public health department in this very important, significant, wonderful county in California, that oversees all of the direct patient care, but of course is tied into all of the public health efforts across the county and all that they do in collaboration with others. CJ, you have a distinguished career in public health and a very fancy medical education and public health service background before getting here. We're so glad to have you. Can you share a little bit more about your background so people know who they're talking to? And then we're going to talk about our theme, which I'm really excited about.
Sure, appreciate that, Ken. And I am CEO of San Mateo Medical Center. I'm also a practicing primary care physician here. And I would say my journey has been not predictable all the time. I wouldn't say where I ended up was incongruent to where I thought I was going to go. But I completed my training at the the University of Pennsylvania in internal medicine. And actually at that time thought I would be pursuing an academic career in an internal medicine subspecialty. And as I was completing my residency, I realized there were other things I wanted to explore, and specifically, I really wanted to take some time to look into public service. And so I took a year off to go and work with the Indian Health Service on the Navajo Reservation in Arizona. And I ended up there for 3 years and realized a couple of things. One, that I really loved public service, and two, that I really loved primary care. Probably a third thing, that I really loved a colleague who became my wife. And she was a Bay Area native. And so we ended up relocating to the San Francisco Bay Area. I spent a couple of years working for a private entity and enjoyed that, but realized that I really missed public service. And that's when I became aware of opportunities in San Mateo County. And really was excited by the prospect of building something new, which is what they were doing. Started as a local medical director in some of the clinics, then became chief quality officer, then chief medical officer, and I've been the chief executive officer here since 2017.
And it was toward the end of that ascension, because of your servant leadership, that we got to meet and help you. It was really exciting to see what you all were able to do to take your operating system to the next level, and it's been great to learn from you ever since. So today, the theme we're going to talk about, and I'm really excited about it, is we have a CEO of a hospital, a public health CEO, that is actually excited about this strategic planning cycle, and there are some deeply embedded, challenging thoughts that are sort of fueling your excitement at getting into this. So, at a time when healthcare is changing and everybody knows they have to sort of look around the bend and look at the future, you're definitely doing that, and you seem fired up about it. So, can you tell me, why are you excited about doing the work of, projecting out, who you want to be and how to get there, 5 or 10 years out right now? What's driving that?
Yeah, I think there's a couple of things. I think one is over the years, as I've been in this role and reflect on the roles I've had before, it's probably been my experience that strategy is an on top of thing, that historically that's how we've approached it. You must make sure that your operations are working well. You do continuous improvement to try and incrementally improve those operations. And then every year you get to think about strategy. But truthfully, in the safety net, historically, you might have thought about that as just another version of that continuous improvement, incremental improvement. And as I've approached this cycle and approached the last few years, I've realized that it's okay that I really like strategy, that's not a problem in any way. And in fact, it might be a prerequisite for having this job, that you want to think about, where are we going? Where should we be? Where should we be 5 to 10 years from now? And one of the challenges that I noted was that previously, when we thought about strategy, it was always from this point forward. So we're here right now. Where do we want to be a year from now? And while we made some great gains doing that, the hazards of not knowing where you were heading longer term have become more and more evident. That you do something, you kind of get it to a point, and then you do something different, and people feel like, well, why are we just jumping from thing to thing every year? It's also clear to me that the traditional role of the safety net is in transition, and that rather than running from that, it's important that we embrace it. Historically, we would have been thinking about ourselves as the provider of last resort, that our mere existence was a good in and of itself, and that is no longer true, which is for a lot of good reasons. As coverage has expanded, especially in California, but I think across the country, we have to start redefining ourselves. And for me, that redefinition is around equity. And that's what I'm really excited about, is what does equitable access to care or access to equitable care look like in 5 to 10 years? And how can we start mapping it out in a logical way? So that's why I'm really excited, is that I'm really enthusiastic about the notion that we can set a target and have some logical steps over the next few years to get there.
And you're tying a lot of very powerful thoughts together. So, not just incremental, but where should we go? And, when you think about it, we've all been saying things are broken and we're not optimizing the impact we should be having on populations for quite a while. Right. So why not think very boldly about a much bigger step toward true north a little bit further in the future, and then work back to how to get there. And you then sort of subtly laid something in there that the role of safety net is changing, and that's part of the driver, and for good reasons. We like that. But you then said you're having to challenge some of the thinking, right? And you said something about, we've been the provider of last resort, and that's good enough. So again, leaders have to align people and lead change and get people to be less satisfied with how things are. So talk more about that dimension, that challenge that you're sort of relishing, of thinking differently on that as your role has to change as a safety net provider.
Yeah, I think one of the greatest assets that I feel my organization has, and I think a lot of mission-driven organizations have, which is that the staff are there for the mission and they're committed. They want to do a good job. They want to take care of some of the most vulnerable populations in the community. But the environment for decades, if not longer, has been one that, and this was true when I joined the organization, that we would celebrate when people left our system. It meant they had sort of graduated, they had gotten a job, gotten insurance, moved on. And if our role was to transition them through that, then our success was, just being here. And the more we could engage others in that work, the better. And I think there's still the remnants of that thinking. But the truth is that if you project that out longer term,
Yeah.
then there is no real purpose for this organization or any similar organization to exist long term. Because if the goal is to get everybody access to care, to get everybody into a system, you can do that without existing as a system yourself. So I think that forces us to think about, well, then what are we uniquely positioned to provide? And that is really building our systems around the specific needs of the populations that we serve. But that is a frame shift for people, because generally, I think healthcare as a whole has difficulty embracing its nature as a service industry. And I think, that's true, in the safety net as well, that we really get satisfaction out of the idea that if I wasn't here, then you might have had a bad outcome, you might have, not gotten care at all. I mean, those are all really important things, but they're less and less true over time. And so being able to think about how do we take all those skills, all that commitment, all that passion, and focus it on how actually we can provide people with equitable care that overcomes the societal barriers that they are encountering. And I guess to really condense that, historically, the societal barrier that we were focused on was lack of insurance. So less and less is that the barrier that our patients are encountering. Now it's food insecurity, it's language access, it is, cultural exclusion. And so how do we build differently around those things? And what does it look like when you're actually built to serve that population?
So this is really exciting. So you said, you know that your true north is going to be around this equity goal, and what does it look like, around these refined needs for the population that you are uniquely qualified to serve, to be, as we say, best in the world at what you do. And this is probably stuff that we want everybody to be able to do, but you certainly could get there faster than others because of all that you know and the people that touch you. So say more about this equity journey. You're starting to lay out some of the things you think it will entail in terms of the needs that you see, where, we see a lot of health systems working to understand what equity really means concretely. And it sounds like you have a head start. So will you share a bit?
Yeah, I totally appreciate that. I think, obviously there are many in your audience, many in the world who know far more than I do. So I just want to preface my comments with that. But I would say that I really appreciate the distinction between equality and equity. This notion that we must reduce barriers and or help people overcome them, and that is going to be unique to their circumstance. And some examples of where I'm excited to expand our thinking. So in San Mateo County, a really important population that we take care of is our farm worker community.
Yeah.
And so when you think about just the way that we're all structured around bricks and mortar appointments, come to us and we'll be a one-stop shop for you. These are all things that not only are standard, but in some ways we thought were the gold standard. One-stop shop, you come to us and you can get everything done. Well, how does that work for someone who maybe can't take time off from work to go do it? Or someone who really, has to think about their priorities with respect to where they place themselves versus their children versus their spouse. And, when, the main issue I have today is the pain that is coming from my job, not, your worries about my diabetes or whatever it may be.
Mm-hmm.
And so I think starting to think about our system in different ways around those populations and recognizing that, building for any one population is a step in the right direction, but it doesn't make you an equity-based organization. It just makes you kind of a unique service-oriented organization. And so I think that's the other thing we're looking at. When we look at our population, what are their unique needs? This is really what I'm excited about in this 5 to 10-year look, is what if we took all the barriers away, what would that look like? And that's where you really hit, it's where the rubber hits the road around things like the payment system and other things. I think that's where we will be forced to grapple with, we've been talking about value-based care since the beginning of my career, and living one foot in, one foot out becomes increasingly impossible. For me, one of the sad pieces of that is we have, over the years, perhaps without intention, actively dismantled things that we put in place thinking that value-based care was on the horizon. And then when it never came, those things kind of just started to back out. So this is a chance to just push forward with a true vision for that 5 to 10 years.
CJ, as you often do, you're tying together some powerful things that I think I'd like to dig into a little bit. So, and some will have to come back to, but this last bit you're saying about the financing system and, is it going to change in one canoe, et cetera. When we talk last and getting ready for this, you talked about we could wait forever and use it as an excuse forever. So you're pushing through and as part of this, helping people see differently about that. Can you go a little deeper into that? Like what clicked for you and then the practical applications of that for how you're getting people to move and not wait.
Yes, I think there's a couple of different aspects to that. Some, pretty straightforward that people are probably doing on as well, and some that I'm hoping will be a little more unique. I would say that I always was attracted to the basic lean principle, as I learned it, of if you do the right thing by your client, the finances tend to work out. It's sort of a secondary piece of it.
Yeah.
And so, it has been my experience that tends to be the way things operate. I also think that I have a lot of engaged partners, whether that's our local health plan that is the managed care organization for Medicaid in our county, whether that is our local improvement groups, et cetera, who are also excited by trying to figure out a direction to go in, but nobody quite has that direction, and that trying to flip the question on its head from what is everybody willing to pay for and how can we get a piece of that pie and move ourselves forward by doing that to what do we want to build and then how do we get somebody to pay for it? And because I think I have perhaps what's the word I'm looking for? Unjustified confidence that what we will build will be very appealing because it's built on all these tenets that we've all agreed to anyways. And so that I think is the big opportunity. And it's a continuum as well. So we have built this out to where we will have some of our work kind of on that sharp end of innovation, where really all the rules are out the door and we're going to try and build it sort of off to the side where things can come into the main operation as they are proven to be effective. But then having a vision for the main operation, where do we want that? That's really what this 5 to 10 year plan is. Where do we want the main operation to be 5 to 10 years from now? And then what would it take in year 1? What would we build on in year 2, knowing that there's always an adjustment that needs to be made? What would we build on in year 3 to get to a model that is ready to get people to pay for value, that is ready to meet the unique needs of our patients, that is ready to define that population very clearly in a much clearer way than we're able to do today.
Terrific. I love the flipping it and creating something powerful and important from a mission and an impact statement and figure out the finances separately. I don't think you're unfounded, et cetera. And if it makes you feel a little better, among the health systems I'm talking to, really the savviest ones, often with people who come from the payer side to the provider side, are really kind of calling the same question and saying, look, we have one system of care. And in your case, you're trying to build one, flow of equity, the creation of equity for the population you serve in San Mateo County. And that it's almost like the rhetoric around value-based care and all of that stuff is really mostly about who bears risk and what the formulas
Right.
are, et cetera. So let's figure out how to flow the best care possible and then make sure we can pay for it and not get confused. What's financing is financing, and what's, fulfilling the needs of the population we serve. That's what we're here to do. And so I think you're on the right track, and you certainly get something that's less chopped up and more holistic and more satisfying for people to work in, right? If you can
Right.
pull all that together. So
I think one of the challenges embedded in that, going back to an earlier topic that we touched on, but it's just reminding me in this conversation, is another driver of the safety net that it is hard for people to let go of is this notion that our doors are open to everyone. That is a truism. Our doors are open to everyone.
Right.
But that's different than saying we are built to be the best for everyone, because it's probably not possible to be the best for everyone. And so deciding who are you really focused on, that is a challenging message for mission-driven folks, because I get it. I'm one of them. The notion that it feels a little unsavory to say I'm not building to be the best for everyone. Acknowledging that impossibility and realizing that, but we can be the best for people that most other organizations don't focus on. That we can figure out what their unique needs are. And we're in the perfect situation. My organization is a fairly large ambulatory system with a relatively small acute hospital, busiest emergency room in our county. We also do skilled nursing. So we have the spectrum of services, and I would argue we have them in the right proportion to be successful. We have a highly supportive government structure. So there's also a little bit of, if not us, then who, that I think drives us in this.
Right. No, that's great. And I also hear in you the way a leader says, well, it's great to have that idea, but how do we make it concrete? And let's focus on some particular populations to make it concrete, and, creating reality, not just rhetoric and what it's like. So CJ, people do planning cycles all the time. They are famously not the highest yield processes in a lot of places, right? And you are really trying to move thought patterns, et cetera. So I've seen you do some very dynamic things. I think back to the death reviews that you started across the county to see the missed opportunities earlier in people's lives and get people thinking outside of the boxes of their particular service silo, et cetera. So we know you're a dynamic leader. So how are you thinking about this strategy cycle and techniques that you have already started using or building on or going to introduce to try to help, the energy flow faster than the fear, if you will?
Exactly. I think that's a great question. And I think over the years, we've experimented with a variety of models and have really had some success in each of them, but to your point, not to the level that we had hoped. And so there's a few things that we've done that I think will really help us going forward. One is I've gotten greater clarity, specifically in the area of leadership development, that when you think about your organization, there are layers of leadership that should appropriately be focused fairly exclusively on operations and how operations gets better and how we run our operations. And then there are layers of the organization that should be spending far more of their time thinking about strategy. And so for the last several years, we've been making, small and large tweaks to our leadership model to ensure that there is a small group of senior leaders who understand it is their responsibility, their role, and their privilege to do this strategic work. So that's one piece of it, is really focusing in on a smaller group. We've also, over the last 2 years, built an improvement model. So our improvement system, leveraging an upcoming EHR implementation, is built around value streams. And so we've identified 10 value streams that we believe contain everything that we do to enhance health for our clients. And we put together staff and an improvement council structure, which will be the execution end of this. And then it really is signaling. So we are about to implement an EHR. There is something of a sense of, there will be a long, 6-month or longer recovery period. And so I've used the opportunity to signal very strongly to that senior leadership team that we are going to utilize that time to get prepared. We are going to dig deep, deeper than we've ever dug before, to really understand what concretely do we want to do starting in July. And map that out. And then we'll bring in the rest of our executive team to get them prepared. But I think it's in the things that are going to be different in this cycle are that although we've done longer term visioning, the process has often felt like we do that and then we put it to the side. Right. we find a small thread we want to follow, then we put it to the side and we follow that thread. This is going to be different in terms of literally the goal is to chunk this up into whatever increments make sense arbitrarily annually for that 5 to 10 years. And then really have very concrete goals. I think that's the other, like you said, that's the other experience that many of us have is we say, we're going to move this needle by 10%. That's our goal. Or if we're audacious, 50%. And then it doesn't move at the end of the year. And what we routinely, the conversation was always, well, those things take a long time to move. Those are, system level measures. They're not going to move in the time frame we gave it. And, basically for us as a team, making that an unacceptable answer. That's not what we're going to do this year. That's not where we're going to end up. So we need to design for something different. And so honestly, I don't know what it's going to look like because it has to look fundamentally different than the way we've done it in the past. And so we have a plan, but we'll be making adjustments as we go along.
Well, that's great to hear, and thank you for letting us in a little bit to your thinking about what will be different this time, since you're trying to get a different result and with a different focus, which is great. Two other aspects we want to talk to you about today, just of the same related topics. One is, another challenge you're having to do the thinking is that you're in public health and the resources are scarce. So this sort of relates to the financing model. Tell us a little bit about that flip you're trying to get people to make.
Yeah, I think for several years now, we have been trying to help our team, in the broadest sense of the word, think from a place of abundance. And it's challenging. I think people will look at other organizations and the equipment that they have and the facilities that they have and think, that's, we don't have that. And there's two problems with that. One, not sure that everything everybody has is actually needed. But two, I think it actually isn't fundamentally true, by which I'll say my organization has a healthy budget. We're well supported by our county. And in California, you have to meet seismic standards. And so I don't think we would be doing as much construction as we're doing if it weren't for that. However, the construction, the county's committed that these are beautiful new buildings that are going up. They're green. They are, organized in a logical way to make the most of the space that we have. I also think that we are trying to, on a daily basis, debunk this notion of I can't ask for. Can't ask for a replacement piece of equipment because we probably don't have the money. The person who is most frustrated by that is my CFO, who believes that he has consistently put out the message. If you need something, let's not only get it, let's have a plan well in advance of when you need it to get it. And so trying to move people into the idea of, and don't begrudge me the questions. So if you ask for something, and I say, so tell me how that's going to improve care or why that versus the other thing, like that's just part of the conversation. It is not a way of saying no. So how can we have more and more of those conversations so that, this is public record. My organization's annual budget is now approaching $500 million.
Yeah.
Based on my background, upbringing, whatever, it is hard for me to think of any entity that has $500 million as poor.
Right.
It's just about how you use your resources. And for us, the challenge is how do we use those resources as effectively as possible to meet the needs of our patients? And how do we make sure that they're getting the best possible care for that investment? And that, I think, is a different discussion than do we have all the toys everybody else. We could, it's fine, we can buy things, but do we need them, or would we be better off spending those dollars on something that has more impact
and toward this more coherent, exciting purpose that you're trying to find through this cycle? And it does bring us right back to what strategy is, which is deciding what work the organization should be doing, and you're really figuring that out in an exciting way. So that's terrific. Last thought, digging under the hood here a little bit to get you to talk about you also unusually link the success of any strategy exercise, which is about the future, to leadership development.
Mm-hmm.
Can you share with the audience a little bit about that deep sync that you've made, and as a framework, and then how you're practically acting on that?
Yeah, absolutely. So I think the best grounding, maybe to use my own personal story first, because that's maybe where I had the most clarity initially, which is to say, as a physician, even as I became an executive, it was grounding for me to say my patients came first. And what that meant was, if I needed to call a patient on any given day, then I would call them, even if it meant I was late to an executive meeting or I didn't do some other activity. Even though I'm only in clinic 2.5 days a week, I will get in the EHR every day and look at what is due for my patients. And it's only been in the last couple of years that I realized that not that I realized I'm the CEO, but that I realized as the CEO, if I am doing other things, then who is being the CEO in that moment? If I am being a doctor in that 30 minutes, then who is CEO that 30 minutes? And so that's the clarity that I've gained, is that at every level of leadership, there needs to be clarity as to what your goals are and what your priorities should be. And that one of the things that maybe has been a challenge for us is that we really value doing. That's just the nature of the thing. And that therefore, at every level of the organization, there was a bit of a sense of you should just be doing a different version of what I do in order to be of value. And then that would go up the entire chain and would effectively keep us in this kind of incremental improvement model, because I need to spend 80% of my thinking on operations and how operations can be incrementally better than it was yesterday. And so part of what I'm thinking about in this leader development frame is that there appropriately are levels of the organization where that is where they should be most focused, but they also should have differential focus on strategy. So, closer to the work, it's really about how does that strategy translate into these operations that are right in front of me. But very quickly above those levels, I have a role in strategy. I may have a role in developing the strategy for my value stream or for my service line, and that I value that getting done. And I don't say I do it at the cost of what I really should be doing. No, that is what you should be doing. And same is true at the level of senior leadership. I think we all came up through the chain, so we all value the things we used to do. So letting go of that and actually really focusing on, if we aren't the executives, then nobody's the executive. And if we aren't actually the people coming up with the strategy, then nobody's actually focused on strategy. And that's fine for the next 2 to 3 years. And at some point, it comes home to roost.
Well, and it's interesting to me as you share that. Thank you. And you've already established how passionate you are about world-class operations, and you've built the systems to make sure that those continue and people are
Right.
supported. And it really is this looking forward, looking out, looking to what more is possible, and how you sort of redefine care, and therefore at the end of the day, hopefully health status more
Mhm.
for your people. So it's always both inspiring and extremely practical, talking to you about realizing our aspirations. And your legend has only grown with me, CJ, because you're willing to do this interview 2 weeks before your full Epic implementation. So
I appreciate that.
um your fellow healthcare leaders listening to this will grow in their admiration for you, as we do this. So thank you for joining us. We appreciate it. Is there anything, a lasting thought that you have for your peers in public health and hospital leadership that, are on your mind about this process or keeping you up at night or?
I think the only thing I would say is that, through everything that we've talked about today, it has become clearer to me, and this is, as leaders, we have a lot of agency. And so the things that ground me every day is I make the choice to do this work, and that I embrace it as a gift, that it is an incredible gift to be the one tasked with doing this. It is not a burden. And so that keeps me going every day, even in the face of this EHR implementation, which is a big piece of the puzzle as we move forward. It's that it's a gift and it's a choice, and I'm excited to have it and to make it. So.
Well, as usual, you are not only challenging others to remake their habits of mind to then drive action, but you are remaking your own as an example. So thank you. And that is certainly, I know, will resonate with leaders with great responsibility everywhere to challenge themselves what has been their internal tape about this stuff, and how could it get more exciting with that kind of flip. So thank you, CJ, for joining us. And thank you, listeners, and those of you watching. We've been grateful to have you. If this is the kind of conversation you want to be a part of, please and subscribe to the podcast on whatever platform you listen to. If you'd like to learn more about how CJ and his colleagues at San Mateo think, please visit the San Mateo County Health webpage. CJ has given public interviews before. Always valuable to hear what you have to say, Doctor. And of course, our website, www.valuecapturellc.com, has resources, including case studies about some of the work we're privileged to support CJ and his colleagues in, and other resources for leaders out there. So thank you for joining us.
Thank you.
And have a great day.
You too.
Thanks for listening to Habitual Excellence, presented by Value Capture. We hope you'll subscribe to the podcast, and please also rate and review it in your favorite podcast directory or app. To learn more about Value Capture and how we can help your organization on this journey to habitual excellence, visit our website at www.valuecapturellc.com.